we have left some minutes for the open house. I think Sudha Sattva has sent me a message. He says one very important point for beginners: the plane of field should always be sharp and push dissection and never blind finger dissection, as Ramesh also said. Second point is Dr. Ramesh already mentioned about tissue welding, and also another thing which helps is bone wax. We have already discussed that. Then he says proper dissection done. We haven't encountered a single bleed actually in our cases. The only initiating bleed in APR is of prostatic venous plexus. Ramesh already held that, and he says we had two cases, one ELAP and one APE, but could be controlled without too much difficulty. Ramesh, on that, I heard, did I hear you correct that you said that now you are doing all APRs as extra elevator APRs?
No, we don't do the extra elevator APRs. We do extra elevator APR only if the elevators are involved.
Okay, so
but
I got
we do all APRs in the prone position.
Prone. Okay.
So we don't do extra elevator. We do the normal perineal dissection in the prone position.
In a prone position. So, Nisar, if you have any question, otherwise I have one or two questions to Sujoy.
Not exactly, sir. I don't have a question. Just a comment. Recently, we had one patient which post-neoadjuvant, she bled significantly from the sacral plexus while dissecting. We tried all measures, including bone wax. It didn't work well. Ultimately, we used Verisat patch also, but pressure packing also. But I don't know exactly whether it was Verisat or the pressure packing. But before that also, we had used pressure pack for at least 10, 12 minutes. We removed the pack, but then patient bled again. Then we got that patch, utilized that. But over that patch, we first applied a gauze and then a pack. So that once we first remove the pack and then see whether gauze is soaking or not. If gauze is soaking again, we just put the pack again. We don't disturb the gauze. Then if gauze is not now soaking, then only we remove the gauze, that too after making it wet. I think that little bit of sequential approach helps in such situations.
Yeah, you're right.
So Sujay,
you're very right that you have to make the gauze piece wet. See, this is something that many people don't remember. They just they think that you have to go in and pull out, So you want your PGs, everybody don't pull. You have to drop half a bucket of water. You have to suck it out, drop it. Till that all the sponge. See, what happens is that you will have 3 or 4 layers of sponges. So the top layer will get wet, but not the bottom layer. So once the top layer gets wet, shake it and remove it. Then again wet the next layer. So that when it is soggy, it comes off. It doesn't rip the clot off. The aim is that you have created a clot by pressure. That clot should not be ripped off, because again the same bleeding will start.
So I was wondering whether bilateral internal iliac clamping during that process, will that help?
I don't know. I have never done it, but the radiologist has done bilateral internal embolization for post-hysterectomy bleeds. There have been significant bleeds and they have done it for that, and they have found that the results are good. We have never required to do it, but I suppose that's an option which you will have if you can't stop the bleeding. Whether that implies that the bleeding is coming from the internal iliac arteries or the collaterals. Some of these patients, especially if you have done a lot of laparoscopic inguinal hernia repairs, you will remember that most patients don't have a vein over the pubic ramus. But some patients have big veins on the pubic ramus because they have an abnormal communication between the external and internal iliac arteries. And these vessels are known as the vessels of death because they bleed. They're very difficult to control because they sort of retract behind the bone and it's not easy to control.
Sujay, I wanted to ask you 2 or 3, not a kind of massive sources of bleeding, may not be life-threatening, but irritating. Diaphragm, lung, and one of the thyroid veins.
See, thyroid vein, I'll start with. Basically, the thing is that you should be able to visualize it properly and take a good ligature, but try and be careful about not being very close to the thyroid or the tracheal margin, because that's where you might end up injuring the recurrent laryngeal. So that's one thing. And for the diaphragmatic, I think you have to just You just visualize it and control it, or like it or transfix it. And what is the third one, sir?
Lung parenchyma.
Lung parenchymal bleeds, we haven't really encountered very commonly, but whenever they have occurred, we have used argon once in a while to control that. So argon is able to take care of that.
So, lung parenchymal bleed occurs in the patients who have got a lot of adhesions of the lung.
Yeah, that's only
The thoracoscopy is usually the
Tuberculosis.
first port is a blind entry. You really don't have ways. So, because it is not friendly, the space between the ribs, you can't put a finger and go in and check whether adhesion. So, you sometimes, gently insert the port for about 1 centimeter and then hope that you have, when you inflate, the lung has dropped already with a bilumen tube, if they've got a bilumen, and you have dropped it with your pressure. But sometimes it doesn't drop and the lung is adherent, and then you put the trocar goes into the lung, and that can cause a
that
torrential
becomes
bleed.
that can.
It can be a torrential bleed. I had a patient who had a apical lesion in the lung, who required a biopsy for the node, and they wanted to do a thoracotomy. The patient didn't want a thoracotomy, they wanted a thoracoscopy. So I did it because we do the thoracoscopic work in our hospital. And torrential bleeding, it's very difficult to control. It took us 6 units of blood to control that bleeding after thoracotomy and pressure. And that can be disastrous. So, and unfortunately, the CT scan or the X-ray doesn't help
Can't
you
make
very much. You can't make out these additions. Unless they have dense tuberculosis, then you know that there's expected. Otherwise, you can't make out. In this case, people
But in the kind of instance that you are referring to, you'll have to perforce do a lobectomy, sir. I mean, a lobectomy,
yeah, that's what we had to do.
or a bit of
We had to
the
do a
wedge of
lobectomy,
that has to be removed. Otherwise,
it has to be removed, and that's why I said, 6 units of blood, that has to be removed. Then she developed an air leak on the ventilator, then slowly recovered. Projected costs became 10 times what it was. See, this is a problem in a private hospital. When you have got this complication, and today I was just, Srinivasan, who's your postgraduate, so he was my postgraduate in DNB study. He came up and said, why is it that when we go on a flight, we can individually insure ourselves for the duration of the flight? The flight has an accident, we can get some money. Why is it that we don't have a similar thing for patients? Why can't we have indemnity for complications, so that in case a complication occurs, they can get some money and that can be treated? So it was an interesting point, but I don't think any insurance company will accept it, because they know flights don't crash, but complications occur frequently. So they will, either the premium will be so high that nobody will take.
So this lung I asked specifically because in our patients, tuberculosis can create problems. And in fact, I remember one patient where, because of extensive adhesions, it was not even possible to enter into the pleural cavity and go up to the esophagus, because everything was plastered. The lung and the pleura, parietal pleura, were plastered together. And in that case, one can have an injury to the lung parenchyma. Dr. Sitaram, any comments from you on all the three presentations, or in general about control of intraoperative bleeding?
I quite enjoyed all the presentations.
Sitaram has no experience in control of intraoperative bleeding. When he operates, there's no bleeding. I've seen him operate. Very clean and neat, sir.
I have 2 comments to make. The first one is Ramesh mentioned it briefly, very briefly, and that is hypothermia. I think hypothermia has got a lot to do with intraoperative bleeding. You have a little bit of bleeding, you haven't paid attention to hypothermia, then that bleeding is accentuated because of coagulopathy, patient goes into acidosis, and then a vicious cycle is started. I think in all patients where major operations you're doing, you should pay attention to hypothermia from the time the patient comes into the operation theatre. Cover all parts that will not be exposed, and pay a lot of attention to underbody mattress, warming mattress. Small things can make a lot of difference in these patients. That is one comment I have to make. The second comment I have to make is that we've all done this Surgicel, Fibrillar, and things like that. If you look at the product literature, it doesn't allow you to leave it behind in the body. You're supposed to take it off after you're finished using it. So we must be very cautious in this litigious atmosphere that we live in. We have to be very cautious that when we use these hemostatic agents, how we use them. I was quite reminded of that when you talked about the embolism that resulted from the use of one of these products. I've seen disastrous complications from these products being left behind, moving, migrating, and creating a lot of trouble. Really disastrous complications. So that is the second comment I have to make. But thank you very much. Thank you.
Nisar, any concluding?
You're absolutely right.
Yes.
We have to ask one more question to ourselves. That some of these products for hemostasis, for using as meshes, they are made from animal products. So you have something made from a bovine tissue. You better be sure that the patients and the relatives will accept the use of a bovine tissue in that patient. I had a patient who I had to do a liver resection, and I asked him and I said that one of these products is made by porcine material. If I have bleeding, can I use it? He said, absolutely no, I'd rather die than you use it. So you have to be very careful. If they come to know that you use it later, you will be in trouble. So better to take consent and to inform them of all this. So I had this. Pentecostal patients won't accept blood transfusions. So I had to remove a huge liver tumor in a Pentecostal patient. So what I did was, I admitted him 6 weeks before surgery. I bled out 2 units, then gave him iron and fluids, then gave him some iron supplemental tablets. Then again admitted him 2 weeks later and took out 2 more units of blood, giving him fluids and iron tablets. So when he came back for surgery, his hemoglobin was 9. But we now had 4 units of his own blood ready. So we managed to do it because he didn't mind getting his own blood.
Yeah, but I don't think any one of us talks to the patients about these bovine or porcine.
Yeah, but I think the time has come that we must, because as long as the patient doesn't know about it, it will be okay. But one lawyer or patient comes to find out this, we will be in suit.
Because a lot of products are of these origin.
Yes, exactly.
I think all heparins are probably porcine origin.
All?
Heparins.
I don't know. The insulin that we use often comes from pig insulin, because that's the closest to us in amino acid match. So, but now of course you have other insulins which are made by genetic engineering, which is better, but they are expensive. So many government hospitals still use the old insulin which they get from the pigs. They don't bother to inform, but I think our diabetologist has been told, if you're going to use it on somebody who doesn't accept it, you better inform them before.
Okay, Nisar, any concluding remarks?
Sir, concluding remark. While preparing for this session, I just came across one interesting term. This is myocardial injury associated with non-cardiac surgeries, MINS. In a recent study published from Korean group 2021 on relationship of intraoperative blood loss and myocardial injury, they found that the threshold for myocardial injury was as high as at HB of less than 9.9. It was extensive work they had done that I wanted to bring to the notice of August audience.
Most of our major surgeries, the hemoglobin at start is below 9.9.
Exactly, sir. That's what. But this is what this was a threshold. This
Myocardial injury they are referring to?
I don't know.
Myocardial injury due to in non-cardiac surgeries because of the ischemia.
Yeah, so it is known. Already it is known.
Yes, it is known.
If you use beta blockers before surgery, you will protect the myocardium post-operatively.
Right,
This
sir.
is a well-known fact.
And
And there
since
are some anesthetists who do use it. routinely.
since intraoperative bleeding is the most common complication leading to intraoperative and early post-operative mortality in surgical patients, and it's the number one killer in the operating room all over the world by its direct effect on the cardiac arrest. By its direct effect, it causes cardiac arrest and permanent neurological damage. So they say that their suggestion was that to transfuse early. Normally, we tend to first resect the organ and then fill up the patient with blood. That has been the general practice. I don't know. Should it have an impact on our future practice? Now, one is that. Second thing is that sir, in every intraoperative bleeding, it's mainly for our residents. Every intraoperative bleeding is not a concern because bleeding is part of surgery, and we don't need to be afraid of it. But it is very important to identify significant bleed, what we call a critical intraoperative bleed, and it has been defined by various parameters. Mainly by the absolute HB level, less than 7 grams per deciliter due to intraoperative blood loss, or more than 25% of the total blood volume, or more than 1,000 milliliters of blood loss. And some general measures which we know, which is more of organizing common sense in some particular sentences. It is like prevention can be instituted by having an adequate access. Many a times we focus, or our residents try to focus on the bleeding itself rather than they lose the panoramic view. They don't have a good access to the area. So access has to be adequate rather than getting panicked. There should be no panic and pressure should be applied. And there should be no delay in seeking a proper second opinion, second help from any senior person who is around in the OT. That crucial time should not be lost. And there should be no lack of preparedness. There should be preparedness at the level. There should be mental preparedness that while you are dissecting at a particular state, that the bleeding can happen. That mental preparedness protects a lot of these panic episodes. And there should be equipment preparedness also. Many times the bleeding starts, and then the surgeon or the junior surgeon, they start looking for vascular set. They start looking for needle holder. They start looking for fine suture. That should be available. That should be tried before we embark on some bigger procedures. And we should be aware of the anatomy, both the normal anatomy and the disease anatomy, pathology specific anatomy. And a very important, interesting thing I was reading about this hospital OR policy. It is desirable for hospitals to have to prepare a protocol for actions to be taken to manage critical hemorrhage. And if there is a critical intraoperative bleed which occurs in OT, a state of emergency should be declared immediately. So there should be a close coordination between the surgical team, the anesthesia team, and the blood bank team, and there should be adequate cover up with the hospital by the hospital administration. Many times, because most of the blood products are donated by the family attendants, when there is a critical bleed which is beyond our expected blood loss, so many times there is a panic and there is lack of that blood. There is a lot of, especially in our setups, we tend to force them to get arranged blood. In that process, we lose a lot of time. So there should be a hospital policy where we can arrange blood and borrow blood so that the patient can be saved.
See, there are policies which are laid out in literature. For example, they say that when should you arrange pre-operative blood? There is a guideline for that.
Yes, sir.
The guideline is that if you use blood in 30% of that operation which you do,
Yes.
you must arrange blood for the operation. Now, how much blood should you arrange? You have to look at your own data and see how much blood was used in these 30% of patients that was given blood. And then you arrange that much of blood. So if it was average of 2 units, you arrange a unit more. You say 3 units. So that in case there is more bleeding. And then that buys you time to arrange more units. But the thing is that many hospitals, they start sending the blood for units arrangement only when the bleeding occurs. They have not done a pre-operative reservation of blood, which is wrong. You must do that. And that is the critical point that you have to this thing. Okay. And in a very humorous fashion, a Russian surgeon has written, stage classification of bleeding. So in stage 1, You just say, I think I got on the wrong side of the bed today. Then when you're more bleeding, he says, why the hell did I come to hospital today? When you're more bleeding, then he says, why the hell did I operate this patient? And then when you have massive bleeding, everything is going haywire. Why the hell did I become a surgeon? That's the final state. So bleeding is part of every surgeon's life. To react like that, I think, is an extreme. You have to be cool. So I am generally a shouting surgeon. I keep people on their toes and I shout. But when there is bleeding, all my nurses know, all my PGs know that when the bleeding is occurring, I am quiet. I am not making noise. I am not panicking them. I'm not panicking the anesthetist, because if I start to shout and panic at that time, everybody will panic. So I quieten them. I back and I sit back and then wait and see what happens. So you should react to bleeding, not with shouting, but by becoming calm.
I think we are beyond 9, so we will.
Sir, I have one question for Ramesh, sir. One question, with your permission, sir.
Quick.
Like, sir, in a patient where we have symptomatic gallstones, in a patient who has portal cavernoma, we are planning a cholecystectomy.
We'll do this tomorrow. We'll do this tomorrow.
What would be your blood asking protocol, sir?
Very clearly, I will give you one line answer.
Right, sir.
I will tell the patient that if you want, I will start laparoscopically, but 95% I will have to convert to an open cholecystectomy. Only if you're willing for that, I will start. I have done about half a dozen of these patients or more also. 50% patients I've had to convert due to excessive bleeding. The other 50% I've got everything. And you cannot do it with monopolar and bipolar. You have to have the best vessel sealing system, which is the Covidian vessel sealer. And you must use a new instrument to do it. Any old instrument has some amount of stickiness. You must use a brand new instrument to do this case, because that is the worst. It's a benign disease, and if you lose that patient, it's bad. So be very careful. That's all. Tomorrow you will discuss it in detail.
Thank you, sir.
Okay. I think we need to close. So I would like to thank Nisar for moderating, and Sujoy, Sadaf, and Ramesh for presenting, and Dr. Sitaram for attending and making some comments.
And me
Thanks,
for
sir.
making the most noise.
Thank you.
Thank you, sir. Thank you.
Thank you.
Good night.
Thank you, everybody. Goodbye.
Good night, sir. Good night. Good night, everybody.